Good morning. Good morning, everyone. Welcome. My name is Jonathan Fellows. I'm the chair of the Black Country Integrated Care Board. This is the first annual general meeting of the Black Country ICB. And as you'll see from the agenda, after this introduction, we'll cover our accounts and our financial performance, the report that we've received from our auditors, some of the key achievements over the past year, and also a look forward to the future. And at the end, there'll be an opportunity for both those joining us online and those in the room to ask any questions. As I say, it's our first annual general meeting, so while we've tried to ensure everything will run perfectly smoothly, please bear with us if we have any unexpected glitches. We do have two British Sign Language interpreters joining us online who will work together to describe the visuals you'll see and also the commentary. So first, a few good housekeeping asks. Please can people put their phones on silent in the room? If you like, pretend it's the cinema. And for people attending online, please can you switch off any cameras and microphones so that we don't get interference and echoes. I can hear some slight ones currently. And obviously, if you have questions at the end, you'll be able to switch cameras and microphones back on then. Should anybody need the toilets, they're on the floor below this one, and there are guides at the back that will help you to find them. There is water available at the back of the room, and all the presentations that you see, along with all the questions that get asked and their answers, will be put onto our Integrated Care Board website as soon as possible. And finally, on housekeeping, importantly, there'll be a fire alarm test at 11 o'clock. The test is a series of short but very loud beeps. However, should you hear a continuous beep, then that's not a test, but it's a real alarm. And in that case, again, the guides at the back of the room will help you to exit the room and assemble at the fire safety point. So thank you for listening to those. So moving on, a little bit of background on the Black Country Integrated Care Board. We were established as an organisation last year on the 1st of July, and our role is to plan and coordinate how we meet the health needs of the almost 1.3 million people who live across the Black Country. We have four priorities, which can be summarised as improving health outcomes, tackling the inequalities that exist in both the access to services or the experience that people find when they need them, improving the value for money, that's always going to be there, but also importantly working alongside our partners such as councils, voluntary sector, education providers and large employers to increase prosperity in the Black Country. And as I said earlier, our role is to coordinate and plan with the delivery of health services taking place in the four areas of Dudley, Sandwell, Walsall and Wolverhampton, which together make up the Black Country. And the closer we can move care to people's homes, the better. Yeah. And this chart is hopefully a helpful one in explaining the systematic approach that we take to health and care. On the one side, the Integrated Care Board coordinates the health and care needs and the planning for NHS services, while on the other side, the Integrated Care Partnership is where we work alongside the councils, the police, the fire service, volunteers, education providers and others to focus on the wider health and care needs of the Black Country population. That's key because health services that the NHS provides only impact on about 20% of a person's health and well-being. The other 80% is affected by factors such as housing, education, employment or income. And as I said earlier, the delivery of health services takes place primarily in our four places, as close as possible to the patient. Only where there's a clear advantage in doing something at a system level do we take that approach. So, for example, our four acute and community trusts working together to improve access and to address waiting lists. Just focusing for a moment on the Integrated Care Partnership, the partners have identified 4 areas on which they want to start working together, which are our workforce, in particular, helping disadvantaged people to access jobs and training, and also to try and avoid poaching staff from each other. Children and families, where we want to offer people a better start in life and try to avoid them experiencing health issues later on. And access to social care and assistance, which I think, as everyone knows, is a significant challenge everywhere in the country. And finally, people's mental health. It's often much easier to see physical health problems, but helping people to have good mental health has to be seen as equally important, especially when you think about the impact that COVID and the isolation that it led to will have had, particularly on younger people, and the resilience it will have required from them to get through it. When the Black Country Integrated Care System was established last year, we produced a short film setting out the reasons for having an integrated care system and the challenges that it was set up to deal with. I think that film remains relevant, so I'd like to play it for you again now.
Hi, my name is Jonathan Fellows, and I'd like to take a few minutes to tell you about the integrated care system we're building in the Black Country. In particular, I want to talk about what an integrated care system is, what it will do, and why we need one. The Black Country has a population of nearly 1.3 million people, and it covers the 4 boroughs of Dudley, Sandwell, Walsall and Wolverhampton. It was one of the birthplaces of the Industrial Revolution, with coal mining, iron foundries, glass manufacturing, brickworks and steel mills, all creating high levels of pollution. The first time this area was called the Black Country appears to have been almost 200 years ago, in the 1840s. It might have got the name because of the soot and the smoke from all those industries, or perhaps it was because of all the coal seams close to the surface. What is clear, though, is that although the heavy industries have now largely gone, their legacy lives on in terms of the impact on the health and the well-being of the Black Country population. Sadly, many people in the Black Country don't live as long as those in other parts of England. A lot also don't enjoy good health and face other challenges. There is a great deal of poverty and deprivation in the Black Country. Just under half of all the people in the Black Country live in some of the most deprived areas of England. There are also more people in the Black Country who don't have jobs, don't have qualifications compared to the rest of England, and children don't do as well in school as in other parts of the country. Healthy behaviours and lifestyles are also important when looking at people's health, as these lead to more people living with long-term conditions and ill health. The reason we need to alter how we're providing health and care to our population is so that we can work alongside our communities to start to change some of those outcomes. It won't be easy, but that mustn't stop us from doing everything possible to make a difference. The population of the Black Country is very diverse. Overall, around 30% are from Black, Asian or minority ethnic communities, although in Sandwell that's a size 40%, and in Wolverhampton it's 39%. Communities include people from Bangladesh, China, Gambia, India, Italy, Jamaica, Nigeria, Pakistan, Philippines, Poland, Somalia, Zimbabwe and Yemen. We need to make sure our health and care services are easily accessible and available to all of them. The environment in which we're born, grow up, live, work and age in, as well as the decisions we make for ourselves and for our families, have a bigger impact on our health than healthcare alone. We know that differences in health outcomes and life expectancy as well as opportunities for good education and job prospects, don't affect everyone equally. So a one-size-fits-all approach won't work. We need to work with each of our communities to help identify the specific problems to tackle, and we'll also need their help to come up with the best solutions. The COVID-19 pandemic has shown us how health and care services can work together better. All services played their part, with GPs, councils, voluntary and community groups working together in local neighbourhoods to reduce isolation, tackle loneliness and support those most vulnerable, while hospitals work together to share resources, look after a lot of people suffering from COVID-19 and also ensure that people who are ill could still get the treatment they needed. But even with all of the great examples of our health and care systems working together and breaking down barriers, we know that for some of our communities, COVID-19 has led to inequalities increasing, not reducing. If we were to carry on as we are, we'll need more hospitals, more care homes, and a lot more health and care workers. Not only is this unaffordable, it also wouldn't be the right thing to do, as it wouldn't help people to live longer, nor help them to live in better health. We need to change. One of the most important things to realise is that health cannot be improved and health inequalities will not be reduced by the NHS acting alone. Although improving the quality and accessibility of health and care will play a part, there are many other factors such as income, education, employment, training, housing, the environment and crime that all have an impact. Only by working together to deal with all of these factors will we start to be able to make a difference. So our integrated care system is a partnership across health and care providers, local authorities, voluntary and community organisations, the police, fire services, housing, education, colleges, universities and large employers aimed at coordinating services better, improving the health and the lives of Black Country citizens and starting to tackle and reduce the inequalities that exist between the different communities across the Black Country. By working together with partners from our integrated care system, we want to improve outcomes when people need hospital care and treatment, improve the health of our Black Country population, remove the inequalities that we currently have in access to health and care, provide care that focuses on the person receiving it and makes the best use of their time, connect health and care services in a more joined up way so that we can make better use of the money we have, and play our part in improving education, training, employment and housing to give our communities better prospects. I said earlier, none of this will be easy, but I also said that mustn't stop us. By 2030, with more people living into old age, some of the things that will help us to know that we've succeeded will be if people are living longer and healthier lives, people are staying healthy in their own homes and communities, people are taking greater responsibility for their own health. When people need hospital care, they get the best care at the right time, and prospects for education, employment and housing are much better. However, there are also two other groups that it will be vital to have deeply involved if we're going to succeed. The first group are the communities we serve, who need to tell us the things that need to change and help us to find the right answers. And the second is all of the people that work in health and care. They have a vital role to play, as they will know what changes will make the most difference. They will know how to do things better, and we need to involve them. Most of the time, our people and our communities know what the solutions are. So we want to listen to them, work with them and support them so that together we can make the right things happen. This will be a new way of working, putting people and communities at the centre of the whole system. I hope you will all want to play a part to help make a difference and to deliver a healthier future for everybody in the Black Country. Thank you.
Thank you for listening. And now I'd like to hand over to Tom, the Chief Financial Officer for the ICB, to take you through our accounts and financial performance. Tom.
Thank you, Jonathan. Can everybody hear me okay? Great, thank you. It's lovely to see so many of you. As Jonathan pointed out, my name's Tom Jackson. I'm the Chief Finance Officer of the ICB, and it genuinely is an honour and a privilege to have that post. There are a number of parts to my role. Mainly, my job is to advise the board on matters relating to finance, but there's also a key element of the role, which is to ensure that as an organisation, the ICB maintains proper financial records and we report our finances in a timely and appropriate manner. Part of that is a production of our annual accounts. I've got about 9 slides that I'll talk you through where we sit with our annual accounts, but also where we are in terms of financial performance for 2022-23. Normally, within NHS organisations, in all organisations actually, the annual accounts and the annual reports cover a 12-month time period. And generally, for the NHS, traditionally, that runs from the 1st of April to the 31st of March. As with all 42 integrated care boards across the country, we opened, if you like, on the 1st of July 2022. So that means that our annual accounts cover the 9-month period from the 1st of July 2022 to the 31st of March 2023. The production of our financial accounts in the NHS all follow a pretty standard format that is given to us by the Department of Health and overseen by the National Audit Office. Our accounts are summarised into 4 high-level statements that effectively analyse the income that we receive, how we spend our money, our assets, who we owe money to, and how the cash moves. The 4 summary statements are supported by a large series of documents, supporting statements, of which there are 20 notes, which some of you may well be very interested in, and you're welcome to go through those in some detail. However, I'm sure you'll be pleased to know that I do not intend to walk you through 45 pages of accounts right now. In terms of where we get our funding from and how the NHS funding works, you will all, I'm sure, pretty much know that the NHS is funded mainly through national taxation. Of all the government departments, healthcare is allocated significantly more than any other areas. Those would include things like defence or education. The term that is used is a vote in terms of allocating resources, and Parliament votes to allocate funding to the NHS, and then the Treasury pass the funding through to the Department of Health and Social Care, who then allocate funding onwards. In this case, as the slide shows, to NHS England, bearing in mind that for the other countries within Great Britain, they're funded slightly differently, that amounted to £153 billion, a significant resource. The majority of that funding then gets passed through to the 42 integrated care boards that cover the population of England. The money is allocated largely based on the size of the population, but there are movements, increases or decreases based on particular population characteristics such as age or deprivation. There's a formulaic approach to do that. As a system, the ICB, we have 2 roles effectively. We've got our own organisation, the ICB, but we clearly have a lead system role. The money that flows through the system can get quite complicated. I'll try to explain it briefly and simplistically. So last year, the ICB received £2.6 billion to cover the health needs of our population. The majority of this funding is given to our main local NHS partners, such as local hospitals and GPs. In addition to this, our NHS partners will also receive money for patients that they treat from outside of the Black Country. And in total, the NHS in the Black Country spent around about £4 billion last financial year. In terms of the money that we are responsible for and how we allocate that, money that we spend on services, most of what people will see as NHS services, is called revenue expenditure. Money that we spend on physical assets like buildings is called capital. The majority of the spend in the NHS is on revenue expenditure for goods and services. For the 9 months that covers this annual reporting period, we received just short of £2 billion to spend on services. The chart tries to show graphically through a pie chart how we allocate that resource to deliver the services, NHS service to our population. With a population of 1.3 million, that means that we spent on average for the 9-month period £1,500 per person in the Black Country. For a full year, that would equate to around about £2,000 per person. Of that funding, the majority, 54%, is spent on care that's provided in hospitals. That would be cares that you're familiar with, such as accident and emergency, or operations, outpatient appointments, and so on. 11% was spent on mental health services, and the balance, largely a further 32%, was spent on services that provided outside of hospital. We would call them community services. That would include community services such as district nursing, as an example, general practice, but also the prescribing of drugs, which is a considerable expense in the NHS. I mentioned that we spend also resource on capital. So in addition to the revenue spend that we've just been through, we also spent last year collectively as a group of organisations in the NHS £299 million on capital items. This includes some general items such as building improvement and equipment replacement, but it also includes some more strategic expenditure with things that you may well be familiar with. So some of those significant strategic projects would include things like the new Midland Metropolitan University Hospital, a new emergency department at Walsall. There's been significant investment, and rightly so as needed, in the mental health estate, and also infrastructure to improve waiting times for surgical procedures and diagnostic scans through what we're calling community diagnostic centres, but then also around elective care. So how did we do last year as an organisation in terms of delivering our financial targets? Alan is the chair of our audit committee next to me, and following this, he'll give you a view of what our external auditors thought about how we did. But in terms of how we dealt with our key targets, we have quite a number of what we call statutory functions within finance. So these are things and duties that we have to comply with. But basically, they're designed to assess, to make sure that we don't spend more money than we've been given, that we use our money wisely, that we continue increase investment in mental health services, and that we pay people on time. I'm pleased to report that for the ICB, we met all of our main financial performance targets for the last financial year. However, increasingly, we are being held to account for the financial performance of the wider NHS system. So that includes the 6 or 7 organisations that we have within the Black Country, the hospitals and so on that work with us. And there are some challenges that were identified in financial performance there, particularly in relation to the delivery of efficiency programmes. Paying people in time, I think, is hugely important. This came in a while ago as a standard, so this relates to the fact that for many suppliers, the NHS is a significant, well, all public sector organisations are a significant contribution to their income, and therefore, as it's funded through taxation, there is a view, quite rightly, that people, suppliers, should be paid on time. Whilst we, as an organisation, hit our targets, which is effectively that we pay 95% of people within 30 days, there are always reasons why that can't happen if things are disputed or for whatever reason it's not quite possible to get to 100%. But we are working with system partners to improve performance across the patch, particularly I think for local providers who would need to make sure that we are paying any invoices that are due in a timely manner. Okay, so I thought I'm going to finish up shortly with a little bit of a forward look, but I thought it just might be informative to give a feel for the sort of things that we do buy, what do we deliver, the volume of activities that are provided for our population on an annual basis. In the last year, the Black Country population, we had 7 million GP appointments, and within that there were 26 million items prescribed. We had 440,000 people attend accident and emergency, with a similar number using the NHS 111 service. There were 1.6 million outpatient appointments. 127,000 people were moved by ambulance, and 123,000 people were treated in hospital as an emergency. We also had what we would call planned procedures. So effectively that means an operation that you go in for or other surgical intervention. And we had 160,000 surgical interventions. Finally, for me, I think we do need to look forward, although we're already now 6 months into the next year and how we can, what the financial strategy might be looking forward. It's absolutely fantastic that we can sit here and report that we delivered our financial targets in the last year. However, it did come at some expense. The ICB, we needed to use a lot of our financial reserves to support one-off measures to deliver the financial position in 22-23. For the current financial year, the year that we are in now, we will receive again the second lowest growth in the financial allocation of all 42 ICBs. This, taken with, and it's in the public domain, I can say that that will equate to 1.6% uplift next year, subject to the autumn settlement that may or may not increase that. This, taken with the financial impacts of, that you were familiar with, high inflation, industrial action, emergency service pressures, and the need to reduce waiting times, means that the next couple of years and this year will be very financially challenging for the whole Black Country NHS system. So to address this, we are working closely to understand the drivers of those costs, but more importantly, where we may be different from an average benchmark. And we're also looking to develop a range of solutions to make us as productive and efficient as we can be as a health system, so that we can deliver the services that we want to deliver and that any efficiencies won't necessarily impact on service delivery. Thank you very much for listening. That's it for me. I'm going to hand over to Alan now, who I'll let introducing himself as we talk about the Audit Committee confirmation.
Thank you, Tom. Thanks for running through the numbers for us for last year. So Alan Edwards, I'm the Audit Committee Chair, as you can see there. One of the Audit Committee roles is to review the draft of the annual report and accounts, and taking into account the findings of an independent external auditor, make a recommendation to those charged with governance, i.e. the board of the Integrated Care Board, about whether they should approve the report and accounts. The ICB's external auditors are Grant Thornton. They are the largest supplier of external audit services to the NHS and local government in the UK, so they're vastly experienced. Their role is to independently review our financial statements to ensure that they represent a true and fair view of the period in question, that the accounts have been prepared in accordance with international accounting standards, and the reporting is in line with UK regulations and law. I am pleased to report that the Audit Committee received an unqualified opinion on the ICB's financial statements on the 30th of June. And that's shown here in this slide. You can see. In their report, they noted that they received a good quality set of draft accounts, and they did not request any audit adjustments to those accounts. I would also note that the auditors are required to review the annual governance statements and the annual report itself to ensure that they're consistent with the accounts. Based on the report that we received from the external auditors, the Audit Committee was pleased to recommend approval of the accounts to the board on the 30th of June. Thank you. I'm now going to ask Mark Axel to talk to us about the year that we've just been through.
Thank you, and good morning, everybody. I hope you can hear me clearly and that those online can hear me clearly as well. I'm going to take a little time to take you through the performance of the ICB over the last 9 months since its inception. But actually, I wanted to just start with a few thank yous and a few reflections from myself. So firstly, at the back of the room, you'll see our annual report. Pulling together an annual report and the documents that come with it is never easy. So I want to place on record my thanks to the finance and performance team, the governance team, who in the year had to close down one organisation in the CCG, but also then make sure that we accurately reported the finances of a new organisation. I'd also like to place on record my thanks to the comms and involvement team for organising today. I know it's not been an easy task, so a huge thank you to them as well. And as Chief Executive of the organisation, and which is a privilege to be, I have the great pleasure of talking about what we've achieved during the year. But actually, that's not achieved with some of the people in this room. So on the very front row, you'll see my exec and board colleagues who lead the organisation in many different ways and in many different roles that we'll talk about today. And a thank you to them for all the work they've done and for working with us in the new world we've inherited. To staff, volunteer and carers, the staff at the back of the room, volunteers and carers in the room with us today, thank you for all that you continue to do. And as I drove in this morning to come into the building, I reflected that in 2019, I was Chief Executive Dudley and Walsall Mental Health Trust at the time and closed the AGM. And I didn't expect it to be another 4 years before we finally held a AGM in person, given the challenges that COVID had on all of us across the Black Country. And I think that's a theme for me of the slides that I'm about to present you, that there are a number of significant challenges in the services we deliver, and the NHS faces unprecedented pressure and demand while still recovering from the impact that COVID has had on all of us. And whilst it's not possible in an AGM in limited time to mention every way that Black Country colleagues have innovated, collaborated in every area, please do take a copy of the annual report, which covers all of it in detail and shares the vast array of services that have been delivered and the way that colleagues have innovated. So over the next few slides, I want to give a snapshot, and it is literally just a snapshot of performance, health inequalities, people and communities, quality, primary care, and how we support our people and staff. The year that we've just been through, the knock-on effects of COVID-19 pandemic continued to impact our overall performance. I think many of us were hopeful as we went through the year that maybe some of that pressure, some of the demands would start to ease. But I think as we look back on the year that we're talking about at this annual general meeting, those 2 weeks before Christmas and the ensuing winter period was probably the most challenging the NHS has ever faced. It was talked about it being sort of the twindemic, I heard it being called, where we saw challenges around flu, strep and COVID-19 putting unprecedented pressures on our organisations. And I think it's acknowledged now widely and nationally that the pressures that were faced during that winter period were probably more significant because all three came at the same time to put pressure on services. and probably more significant than some of the pressures that we faced during that COVID era. On the slide on the screen, we outlined some of the key constitutional standards that we are expected to meet. But actually, we can't list them all and we wouldn't have time. So during the year, A&E performance, the 4-hour wait target was at 72%. In terms of ambulance waits, category 1, 8 minutes and 10 seconds. Ambulance category 2 waits at 34 minutes. And in both of those, we've continued to make significant improvements, recognising the challenge it has and the impact it has on our population. And I'm really pleased to say at this point in time, as we started the new year and even now, we have some of the best ambulance response times for category 2 in the country and the best 4-hour wait performance in the West Midlands. So urgent care is one part of what we deliver. But also it's important that we continue to recover where things had to be put on hold during that COVID pandemic around both elective and cancer. From an elective perspective, so for people waiting for operations and surgery, the first step during the year was to get down to people waiting 104 weeks. Now that for all of us sounds like a significantly long time, and it is. And none of us are complacent that we still need to do more to continue to improve and to continue to drive improvement to address those waits. But we were the first ICB in the Midlands and East Midlands to get to the point of having nobody waiting more than 104 weeks. And then the next step was to get them, bring that down to 78 weeks. And now we just have a handful of patients that we are now waiting to treat, with the aim being that we'll have eradicated 78 weeks by hopefully the end of November. So a lot of work has gone on in this space. And what I've been really pleased to see is that really taking on the learning from COVID, our acute hospitals, which Jonathan listed at the start, working in a way that really took the learning from COVID and making sure that wherever possible, patients get treated as quickly as possible. And that really builds on the work they're doing through the provider collaborative. So how do they work together? And I've seen examples where, for example, an individual may not be able to get the treatment in time they want, say in Wolverhampton, because there's not the capacity and the specialty in Wolverhampton, but to be able to offer that patient the surgery in Walsall if they choose to do so. And the ability to be able to offer that and for the trusts to work together and to look at where they've got demand and capacity and match it has meant that we've been able to make significant strides in that area. We also recognise that cancer waits were significantly also impacted by the pandemic. The aim is to get nobody waiting for longer than 62 days. And as a system, we were set a trajectory target of 368, no more than 368 waiting greater than 62 days, which again was a significant reduction from its peak at the end of January 2022. And by mid-March, our colleagues and our partners in the system have made significant strides to continue to reduce that. And as we sit here today, as we go into the new year, we're already ahead of where we need to be in terms of 62-day delivery and making sure that nobody waits over 62 days. And on the screen, you can see that there were 400, our plan is for 474 by the end of March 24. And we are well on our way to achieving that and moving beyond that. Can we move to the next slide, please? This is a great example, and there are so many of them, we can't include them all in the slides, where we have innovated across the Black Country. And this is the Ambulance Receiving Centre at Wolverhampton Hospital. So the Ambulance Receiving Centre was set up recognising that we need to do more to ensure that patients, when they arrive at hospital, are moved into an environment that's most appropriate for their care, recognising the demands that they have. This Ambulance Receiving Centre opened in January 2023 and has immediately started to improve the experience of hundreds of patients each week. And most importantly, allowing the ambulance crews and paramedics at West Midlands Ambulance Service to be able to respond more quickly to the calls that are coming in. So this Ambulance Receiving Centre can receive an additional 17 ambulances and has additional staff in place to support the safe handover and to ensure, alongside working with our partners in One Wolverhampton, that we have plans to ease pressure in our emergency department and to ensure patients are getting the treatment as early as they possibly can. And during the winter last year, and I think Tom gave you an insight into the significant activity that goes on across the Black Country every year. During the winter last year, an average of 450 patients per day, 3,150 per week were arriving at that ED in Wolverhampton. And approximately 100 a day or 650 a week will now be received into the ambulance receiving centre. Obviously, those that need resuscitation go straight through immediately to resuscitation, but it's a model that we've looked to replicate across the Black Country, and it's an example of best practice that's been shared through our partners across the system. Next slide, please. As well as making sure that we continue to deliver and improve frontline services, as Jonathan's described in both his presentation and his video, we must make sure that we tackle the health inequalities that are evident and present in our communities. And through the work of the exec team, and in particular TAPS, working with our partners across the Black Country, we absolutely recognise that to work in a different way, and I think on the video that Jonathan was in, he said we need to change. That's absolutely correct. We can only do that if we work closely with our partners in local authorities, in housing, in the voluntary sector, the university sector. I'm sure there's partners I've missed there, but I'm sure you understand that 80% of a person's well-being comes from beyond the healthcare support that they get. It comes from, for example, good housing. It comes from supporting people who are lonely. It comes from supporting people to get into employment, as examples. And what you'll see there is some of the significant strides that we've made in this area. And actually, we've been highlighted nationally as an area that's really innovating in this space, to work with partners that probably 6, 7, 8 years ago we wouldn't have worked with. So, for example, on there, you can see the housing partnership that we have with Walsall Housing Group in that year. But that's actually grown beyond that since this annual report. And actually now we work with nearly every housing partner across the Black Country, recognising that housing partners know their tenants best, know their tenants well, can sometimes show an early indication of where support is needed, but also in another way, in identifying potentially people who are tenants of housing groups that maybe need support to seek and access employment. And as health and care, we are one of the largest employers in the Black Country. And in Walsall, we've seen great examples where Walsall Housing Group have worked with Walsall Healthcare to support people to seek and gain employment. And it's something that we really want to continue. So, for example, we're working with West Midlands Combined Authority, with Department of Work and Pensions money, to support people with long-term health conditions right across the Black Country and wider, to seek employment and to stay in employment, and to work with those employers to make sure that those colleagues feel supported. Next slide, please. As well as doing this, it's also really important that we involve local people and communities. And it's great to see representatives from the community in the room today. Our approach to involving people and communities is really in 6 core themes, and you can find more information on those core themes on the website. But broadly, it's be accountable to our people and communities. And that's something that I think is really important in the role I do, and I know the rest of the board feel the same. Recognise that in delivering services that one size doesn't fit all, that actually the services we provide in one part of the Black Country need to be nuanced and different to recognise the needs of a population in that part versus potentially a different part of the Black Country. That in thinking about how we do things, that we start with people and communities. Trusted voices are key, that we continue to invest in people and communities, and that we nurture those relationships across the ICS. And I know as a board, we are particularly cognizant of the fact that as an NHS, sometimes we can impose solutions on our population. So when we talk about nurture, we do mean nurture. We want to listen and shape it with you. And actually the best way for you to experience and hear that, I think, is to hear directly from some of our local people. So we can play the video, please. That would be fantastic.
In 2022, we co-produced and published a new approach to evolving people and communities built on the foundations of 6 key principles. Be accountable to our people and communities. One size doesn't fit all. Start with people and communities. Trusted voices are key. Invest in people and communities. Nurture relationships across our ICS. In this video, we share our progress so far in achieving the principles. But first, let us start by hearing from Sam and Sarah on why it's important that we start with people as the experts by experience to deliver our clinical priorities.
Why is it important to go out into the community?
So then people get their voices heard across the different countries, and so if they don't get their voices heard, then they won't be able to communicate with other people in the staff and the community.
Okay, and is that important that everybody in the communities gets the voices heard?
Yes, so then it gets out there a lot better and so people understand other people.
Why do you think it's really important for people with lived experience to be a part of the things that we're doing?
Because then it showcases off what I've learned and what kind of lived experience I've got, so then they know a lot more about me instead of coming in and just going, well, what have you got? I can showcase off everything that I've learned and how far I've come till now.
Okay, so could I do that? Could I tell somebody about your life?
Because you haven't got lived experience.
Okay, so I could share your information, but I wouldn't be able to tell people how you feel or how things are going. And do you think our experience would be different because I've got learnt experience and you've got lived experience?
Yeah, a lot more, because you're learning, but I'm living it. I'm living it out in the big wide world.
It's crucial that we are accountable to people and communities, that we listen, act and feed back, and that we involve people from the beginning. In developing our joint forward plan, along with a public survey, we also reached out to groups that could help us seek the views of those underrepresented communities. The microgrants funded groups such as Aspiring Futures to hold conversations on our behalf. Let Manta tell you about her experience.
Because we're connecting to women at ground level, not at the NHS or in front of a secretary to the doctor, they're actually being able to have the confidence to come to us and say, you know what, this isn't working for me, or this is my problem and I don't know where to go from here. So we've been able to find out what can actually happen or what can we actually do to alleviate their pain. So it's quite a sort of an eye-opener in some instances that people are feeling this, and we wouldn't know that unless we did these sort of surveys to find out from ground level what is actually facing the women that we're engaging with. Women and people from the ethnic minorities and the community are being listened to.
We know that one size doesn't fit all, and that we have to work harder to recognise the reasons behind the issues that some communities face, ensuring that insight is sought and used to make changes. Investing in people and communities to build capacity, confidence, and help us find the solutions to the problems we face together. One example of our work in this area is the work with Wolverhampton University to understand the barriers for women from African Caribbean heritage to accessing cancer screening.
This project has 2 main aims really. Initially we want to hear from the women across the Black Country in the voluntary community and social enterprise sector. We want to hear and listen to what their experiences are so far of accessing screening and breast screening services within the NHS. And then we want to capture that narrative and we want to bring it to health commissioners and health leaders in the Black Country. So I'm really excited about this project. I'm really hoping that it's a good community engagement project with really positive health outcomes. I'm hoping that the women and the Black and Caribbean communities will have a design solution that they can own and take forward themselves.
I think the difference it makes when you invest in communities is that you can actually speak with the community to find out what their needs are, and to create solutions. And another reason would be to boost confidence and give people a sense of purpose, especially due to the pandemic, when a lot of people have been isolated. And by working with them now, they're coming forward and they want to engage, they want to meet other people that are like-minded. So it's not even about gender, it's not about race, it's about everyone having the same goal. I think it links the bridge of trust, because there is some trust in issues to do with authority and the NHS, and having the committees on board at grassroots level, they know their clients and beneficiaries, and they can feed back and get more honest and open responses, and then we can be the bridge that links the community back to the NHS and vice versa, and then make changes that are relatable to people.
Trusted voices are key, and we are committed to continue working with the community and voluntary sector along with Healthwatch as key partners in this space. Hear from Sarah Taylor about our research work in this space.
With a successful REND submission last year, which stands for Research Engagement Development Network programme from NHS England, we now have the resources to create a community research-led programme that will not only train up voluntary sector organisations to conduct research and evidence their work themselves, but it really also complements the clinical data that we have. By doing so, mirroring up the two, we have an opportunity to really unlock what creates health solutions at community levels and what unlocks changes in behaviour that will help to alleviate the worst in our health inequalities.
We can't do this alone in the ICB. We recognise that for us to be successful, we must nurture the relationships across the ICS to further collaborate, share learning and knowledge, hold conversations once, and support each other to make the right connections. Over the last 6 months, we have developed people panel spaces in each of our 4 places with partners. Hear from Matt from Wolverhampton about what it feels like to be part of these, and from Emma about how these spaces have been used to support our work on digital inequalities.
Taking a joint approach has enabled us to reduce duplication across the health and social care engagement landscape. We've been able to work more closely together and develop a community of practice around engagement. This includes working with partners across the city, and one of the advantages of this is it means that citizen insights can be heard by multiple organisations without the risk that people feel they're repeating themselves. As part of this, we've co-hosted 2 people's panels. These are public-led spaces where the agenda is driven by the public and focuses on areas they wish to talk about. The space has proven really valuable for us, and we've been able to harvest the feedback and insights gained from these panels and have used this work to support our priorities as One Wolverhampton.
The ICB Involvement Teams People Panel really is about bringing communities together and helping to identify the Black Country's grassroots community groups. They are really in the heart of everything that we do. So attending the People Panels allows us from a digital inequalities perspective to listen and hear about what people want in terms of digital transformation and digital solutions, and that's really important to us. The People Panels also enabled us to make more connections with diverse community groups, and we've been able to offer our Black Country Connected programme, whereby we're giving a geobook laptop connectivity, and we've got a support service to help people engage and access health and care services, such as the NHS app. It's also helping them to upskill themselves and help them with wider determinants of health, such as applying for benefits, housing, unemployment, education. And without the People Panels in this forum, we might not have been able to reach as far and wide as we have done.
This is a journey that all ICBs are on, and we value the support from NHS England partners like Liv, who has a message for those working in this space.
We've been connecting with colleagues in the Black Country and really just observing the wonderful stuff that Stephen and his team have been doing to really connect and engage with local communities across the whole of the Black Country to listen and learn about what they think and what they need from our health services. It's been brilliant work, and my challenge to all of you, if you're listening to this and you're in a senior decision-making role, is what are you going to do with what has been heard, what has been said, the stories, the ideas, the gifts that your communities have given you, and how are you going to keep those communities involved so that you're constantly checking back and working with them about what comes next, because we'll only improve the NHS and make it really work for people who use services and for staff who work in services if we involve them and build on what they know works and what they need.
Thank you. That's a great example of what we receive at board every time we meet. And this afternoon, it's our public board meeting, and it's an opportunity to hear directly from the population on so many different topics during the year. This afternoon, I think it's about mental health. That people are nodding, that's correct. And I'd say to anybody that wants to attend our public board meetings and ask questions, or just to chat with us before or after the meeting, please do so. Next slide, please. Whilst there's a lot of activity to deliver, it's really important that we keep our focus on the quality of services that people experience. And under Sally's leadership, it's been a year, I would say, of really strong delivery in terms of making sure that our governance structures, the way we scrutinise the quality of the services in the Black Country, is robust. And it's great to see that the Black Country has been identified as an area where we're actually sharing our learning around quality improvement and quality methodology with other parts of the country. But it was also important that we refreshed and reviewed our long-term quality strategy and did that in partnership with our 4 places. So the key clinical priorities for 22-23 in terms of supporting an ageing and ethnically diverse population, the priorities remain foremost and will be carried forward into 24 in terms of in the right way, that care is delivered by a workforce that is highly skilled and motivated, at the right time through accessibility, in the right place in terms of providing treatment that is as local as possible to the population that we serve. I will wait for the fire alarm. Thank you. The population that we serve, and with, most importantly, with the very best outcomes and the right outcomes and the quality that people would expect. Next slide, please. Primary care is an area that we continue to grow and develop. As you can see on the slide, we continue to offer more primary care access than ever, and during 22-23, our practices delivered an extra 675,000 appointments compared to 2019-20, an increase of 10%. But we recognise that there is significant demand out there for primary care. So as an ICB and with partners in partnership with our primary care colleagues, we continue to do more to offer different ways to access primary care. And this afternoon at board in our public meeting, we'll receive an update on primary care development and how we can continue to grow that capacity. But over the past year, we've included developments around improved telephone access, digital access, to ensure people can get access in the most appropriate way. More flexibility in terms of when appointments are offered, and increasing the use of other primary care providers. And that's something that we will continue to grow and develop over this year and in future years, particularly recognising the challenges around our primary care workforce, the different roles that are carried out in primary care practices to support the population. And in this year in particular, in a new year, thinking more about the roles of community pharmacists, optometrists and dentists, and the roles they can play in supporting the population in the community. Next slide, please. As I said at the start, and I said a thank you, we can't do what we do without our fantastic people. And through Shajida's work, we continue to make sure that we do all that we can to support our staff in delivering care and we recognise the huge role that they have in delivering our system plans, but also their desire and our desire to see the whole Black Country working as one workforce. We absolutely recognise that as an ICB, this has been a challenging year for our staff as we've gone through another change for them, as we've gone from CCG to ICB, recognising this is a year of transition for them. And lots of support has gone into making that transition as effective as possible. But also we are living in a year of increasing cost of living and also industrial action. And we recognise that our workforce across the Black Country and our amazing colleagues need support during these times. And all of our partners, including the ICB as an organisation, continue to do that. Our Forum for Race and Equity and Equality and Inclusion networks continue to work really well, and it's something I'm really proud of, to support staff on several fronts. We have increased the representation of staff from Black, Asian and/or minority ethnic backgrounds from 23% to 31.7%. And the Inclusion Network has several forums who provide support to the staff of the ICB, including the Women's Health Focus Group, who hold monthly face-to-face coffee and chat meetings. They held a well-attended menopause workshop to provide education and awareness. And they also supported staff in attending formal mental health first aider training, which increases the awareness of the support that colleagues need with mental health, but also equips our staff with the tools to be able to support colleagues. Next slide, please. Other things that we continue to do more widely as a system, the LGBTQ+ focus group coordinated the ICB representation and attendance at the Birmingham Pride in September 22. We continue to support staff recognising the pressures and the challenges they're under, and our target is to be below 3.5% for sickness, and the ICB was at 2.58%. Our turnover for the year was at 14.62%, which is below the national average. And we're really focused on making sure that we retain our talented staff and support them. And every year we have the opportunity to hear directly from our staff as in the national NHS staff survey. And in our first year as an ICB, that was particularly important to hear how staff were feeling about change. And was delighted that 81% of our staff took the opportunity to feedback how it was feeling, but most importantly, that we did something about it. And we involved our staff in making those changes. So we set up focus groups to focus on particular areas that were led by staff, including increasing collaboration, how their roles can make a difference, staff experience, work-life balance, and staff development. Next slide, please. I've already talked about the Women's Health Focus Group and menopause cafes. This is something that we continue to grow. The focus group supported the launch of 2 menopause cafes as part of World Menopause Day in October 2022. We also, as an organisation, have signed up to the Menopause Workplace Pledge. And the Women's Health Focus Group have also implemented a buddy system, who each have their own buddy system for colleagues who each have their own experience and to offer that confidential support. Next slide, please. Just finally from me before I hand over to Jonathan, the NHS moves quickly and it celebrated its 75th anniversary in July. It's been a great privilege to be the Chief Exec of the ICB. I think we've made great progress in what we've achieved. But as Jonathan says, we need to change and we can't stand still. And for me, the coming year is about partnership at place, in our collaboratives, and our wider partners are in the room, as well as delivering on some significant projects like the Midland Metropolitan University Hospital, which will open during the year. And we must not forget our amazing staff. Tom's put some figures up there earlier on that I quickly jotted down. 6.9 million primary care appointments, 3 million acute appointments. And that didn't include the work that volunteers do, carers do, our social care colleagues do, or the ambulance service do. So I want to end with a huge thank you to every member of staff within the Black Country ICB and ICS, to our volunteers and our carers, because we couldn't deliver that year without you. Thank you.
Thanks, Mark. So, looking ahead, we recently published the joint forward plan for our integrated care system, which sets out our ambitions for how we want to improve health services over the next 5 years. The Black Country does face a number of significant challenges. You heard earlier from Tom about the financial pressures and challenges we're going to have to deal with going forward, whilst the short film earlier also highlighted other challenges such as low healthy life expectancy, high infant mortality, the number of premature deaths from cancer and cardiovascular disease, and also increasing levels of diabetes. We worked with partner organisations and also, as you heard from Mark's video, you, our population, to produce the joint forward plan, which is available to read in full on our website, along with a short summary. And that plan focuses on 5 key areas, which are improving access to and also the quality of health services, getting better outcomes when we treat people, reducing the health inequalities that people face, giving people a better start in life, and making the health and the care organisations in the Black Country the best places to work, so that people want to come and work with us and want to stay and work with us. And together, those 5 priorities will help us to deliver our ambition, which is to make the Black Country a healthier place with healthier people who have healthier futures. So here is the opportunity for you to ask any questions that you may have. We've had a number of questions that were submitted in advance, so I'll do my best to respond to those now. The first one was from Paul Ryder and Marcus Cottrell from the LGBT Sparkle Social Group in Wolverhampton, who shared some of their experiences around recent service use in relation to correct use of pronouns, language barriers between staff and patients, use of British Sign Language interpreters, and the use of jargon when in hospital. All of those areas they felt could usefully have things done to improve them. So first of all, thank you for the question. And thank you for being such an active group locally as well, supporting people and also contributing to our involvement activities. I understand some of the issues that you've raised have started to be addressed with the providers concerned, and obviously, I would apologise on behalf of the system for the poor experiences that you've had. I think it's really important that these issues are raised, and they're raised openly, so we can continue to learn and we can change behaviours. There's a lot to do, and we can always do more. But as an ICB, we do have a number of things that we can point to as progress. All our staff are encouraged to normalise the use of pronouns through our email signatures, and a great many are already doing that. We've recently reviewed access policies for our providers to ensure they're aware of the requirement to offer interpreters and other accessibility standards. Where we hear of poor experiences, we work to resolve those locally and to educate the people involved. And we're also undertaking currently a review of our own and the primary care contract for interpreters, including British Sign Language, as we've heard the feedback from service users about that. So thank you for the question.
You're welcome.
The second question is from Stephanie Thompson, who's a policy manager for the Stroke Association, and asks that given stroke is a leading cause of death and disability, and that stroke survivors often leave hospital with multiple disabilities, many leading complex and lifelong care and contributing to delays in their discharge and pressures across the social care system, how does the Integrated Care Board plan to fund and resource the integrated stroke delivery network? and what protection and security can we provide to the committed and valuable stroke network staff who are working tirelessly to improve the quality and safety of local stroke services. I think both the Integrated Care Board and the wider system recognise the importance of meeting the commitments in the NHS England long-term plan around stroke and stroke services. And our acute provider collaborative is providing the clinical leadership in this area. They're overseeing the work of the local stroke collaborative and clinical leads to look at care pathways around stroke services and also around stroke rehabilitation services. So hopefully that provides an answer. Thank you, Stephanie. Brian Albert, on behalf of Sandwell and West Birmingham Pensioners Convention, has asked a number of questions. Actually, the first one is, what is the end of life strategy for the Integrated Care Board? And in particular, he has concerns about provision of end of life and palliative care services and support for people who are approaching the end of their lives, but also support for their loved ones as they deal with that living in Sandwell. We have a palliative and end of life care strategy which has been developed for the Integrated Care Board. It's in line with the nationally set 6 ambitions. We've undertaken assessments to understand the maturity of POLC provision and to identify areas for further development. All of our 4 places, including Sandwell, have improvement plans to ensure services meet the needs of their population. Specifically in Sandwell, that plan focuses on areas including education and training of staff that work in end-of-life care, working to improve the early identification of individuals who are facing end-of-life care, working to ensure that bereavement support is more readily available to the people of Sandwell, and also developing partnerships between primary and secondary care clinicians and also voluntary and community groups so that we can work together to build a compassionate service and a compassionate community. Ryan also asked the second question, which is what progress has been made in reducing ambulance waiting times for urgent health treatment, elective care and standing times, which I presume means the amount of time spent waiting outside hospitals. As you heard from Mark's presentation, we are consistently the best system nationally for ambulance turnaround times, but it doesn't mean that we're complacent about that. We're working with colleagues across the system from all our partner organisations, and the annual report sets out some of the work we did last year, and as I say, you heard today from Mark about the improvements that are still going on. We have reports to each of our public board meetings that set out how we're progressing, what progress we're making in reducing the number of ambulance waits at our emergency departments, the number of patients waiting in emergency departments and how many of those are waiting for how long. And we are on track to have no patients waiting for more than 65 weeks for treatment by next March. That's still not enough, and we need to go further than that. And finally, Brian's third question is a practical one. Thank you for this. It's expressing a concern about the timing of this AGM. As he said, a 10 o'clock start is too early to enable members of the public that are travelling by public transport to attend the AGM. I said at the beginning, we wouldn't get everything right. And I think it's great that so many people have been able to join us either in person or online for our first AGM. But clearly we'll take on board the feedback and we'll look to take account of it as we plan future events. And finally, in terms of the questions in advance, Dr. Hua Vitarana has said there's not an up-to-date service directory encompassing community, voluntary and secondary care services that are commissioned across Walsall Place. and that presents significant obstacles for GPs in delivering effective healthcare because they don't know where to refer people to. And she asked, would the Black Country ICB consider prioritising the development and maintenance of a cloud-based service directory in all 4 local areas to serve residents better and meet the healthcare needs of the community? And thank you very much for that suggestion. Our digital and commissioning teams are currently looking into it. There are some solutions, partial solutions in place that provide some of that information already, including the NHS referral service, which has publicly available information on services for first outpatient appointments. But clearly there's a lot more we can do. And I think having a greater understanding of all the services that are out there in the community is key. So it's certainly something we'll follow up. So that deals with all of the questions that were submitted in advance. What I propose to do now is to take any questions from people within the room, and I'll take those next. And then if people online can put their questions in the chat, we'll deal with as many of those as we can today. But rest assured, any that we run out of time for will get put onto our website along with the answers. Right, so people in the room, I think. So,
yeah, can you hear me?
Yes, we can.
David Byers, one of the public governors with Black Country Healthcare. Hello, Mark. Familiar face. I want a really quick response. 3 little points. Firstly, when you talk about the services that you... Oh, I've got a bad back. You talk about the services that you specify in fund. Is it an oversight where you say mental health and learning disability services, but not autism and ADHD services? Surely you fund those services as well. Well, they're not, you said they're not listed.
Yeah, absolutely we do. And we work really closely in partnership, as you know, with Black Country Healthcare.
Well, I know Warsaw had a great service, but we've now got one in Sandwell.
And actually LD and autism is a service, particularly in LD, that we've seen a great improvement from the work that Black Country Healthcare have done. So yeah, it is part of what we fund.
Yeah. Secondly, we're both members of our local medical centres, PPG, and one statistic that I would have liked to have seen on the GP appointments did not show us, because it's not just us. It's not just a Black Country, it must be nationwide. It's a major thorn in the service.
Okay, thank you.
Yeah, and
Saab, you want to come back on that? Do you know the figures?
Yeah, I think the national figure did not attend in primary care appointments is about 6 or 7%, and that's the same for the Black Country.
Yeah.
So that does equate to about something like 60,000, 65,000 appointments across our system, and we are working with the comms team actively to make sure that if people can't attend, they cancel so that other patients can take those appointments.
Yeah.
But it is an issue, and we're pretty much the same as the national average.
Yeah, and finally, waiting time for operations. I feel it would have been much more meaningful to everybody here if you took operations in bands. Let's say at one extreme, a condition where it was clear that if it was not operated on, the patient would die within 2 weeks. At the other extreme, I won't say trivial because it's not, but minor cosmetic procedures that have been approved because a failure to do so would impact adversely on the patient's mental health. And then if we could have for each of those bands, let's say lower quartile, mid and upper quartile waiting times, because just to say these are the waiting times doesn't give us the picture. I mean, I was lucky. I waited 18 hours for a life-saving operation, basically because the paramedics didn't know what was wrong with me. Sandwell didn't, where I was looking at sent me to the QE. And I was in QE half an hour, I was on the table. And then recently at Sandwell General, I got to wait another 3 weeks for a doctor's appointment. I went to the drop-in at Sandwell General. The doctor took one look at me and said, "You're not going home, you've got a bed." And she said, "You'd have been dead within 2 weeks." So I'd never see the doctor. So I say, if you could sort of give us that context of how severe the need is for the operation and the waiting times. Thank you. I'll let you breathe now.
Thank you. And Anita, do you want to come back on that last point?
Yes, thank you, Ananta, the Chief Medical Officer. And it's a very important point you raised, and I was actually making notes when you were talking just so that I could take it back to my team. I mean, you know, the waiting times are, we try and see, we have a range of clinical policies which would help us determine the way to prioritize treatments when people are waiting, taking a range of factors, you know, including threat to life, quality of life, etc. So it isn't a simple unidimensional exercise, but I think the points you make are relevant. So I will go back and have a look at how we can classify them or analyze them or disaggregate or break down the data in some more detail so that we can make sure that the people are being prioritized for the right reasons and people who need help the earliest are getting help the earliest. As I said, there are a range of policies and prioritization frameworks to do that, but I think it's about how we communicate that about what we are doing and to make sure that we are prioritizing the right people. Thank you for raising it.
Thank you, Ananta. Brian, do you want to add anything to that?
Yeah, just add to that. I'm Garen Griversdale. I'm the Interim Director of Delivery. Just to give you some assurance, everyone who is on the waiting list has a prioritisation category from 1 to 4, where 1 is really urgent, must be treated within a month, up to the patients that you see that are waiting up to 65 and 78 weeks have been given the lowest clinical priority based on an assessment by their consultant. Once patients have been waiting for several months on a waiting list, they are continually reassessed so that we can make sure that if their condition deteriorates, they are given a faster waiting time. So we can give you a breakdown of the numbers in each of the categories if it's helpful, but just to assure you there is a regular clinical prioritisation, and those with the highest need are seen quickly and don't wait for those maximum waiting times.
Thanks, Grant. Right, Paul, I think you're next.
Can you hear me? Firstly, I'd like to say big thank you to the integrated care system for listening to my feedback on Easy Reads. So that's the first thing I wanted to say. My first question is, I keep hearing it a lot. We always wait until someone's in crisis with their mental health, and early intervention is the key. So this massively needs to be improved. That's my first question.
Thanks. Ananta, do you want to come back on that?
So yes, I mean, just as we were talking about physical health conditions, firstly, Paul, thank you for that question. I mean, the aim is to have early intervention so that people don't have to wait till there is a crisis. I mean, it puts a huge pressure not only on their own experience, but for carers and for people looking after them, volunteers, etc. So there are early intervention services, and there are also primary care-based services, various multidisciplinary professionals who work within primary care. But we have also seen that the demand for mental health services has gone up exponentially, especially over the last 3 or 4 years. And the demand has increased anything from 26 to around 50%. So there is, I think, the available staff and the services and the way they're configured are constantly working to see whether the kind of services and policies we have are actually meeting the demand and working on the feedback that we receive from people. It is an issue around the demand that has come in for mental health care, and we realize that the earlier people are given help, the better it is not only for them, but for everyone else, and that those who are in a crisis where immediate treatment is required will get the help as quickly as they can. It's not only within health services, but there is also work going on through the Black Country Lead Provider Model and the Black Country Trust, working with local authorities, voluntary organizations, and even the ambulance service to make sure that people are getting help in the right way and not waiting till a crisis erupts. Thank you.
Can you hear me? Sorry. I don't know if it's relevant to this meeting. My second question is, I've been talking to a lot of the community about the care system, because obviously I look after my nan that's got mixed dementia. And when I'm talking to just people generally, they're like, well, I've left the care industry because it's not how it used to be. There's no compassion. It's gone. So that's my second question, if it's relevant to this meeting.
Thanks, Paul. Grant, do you want to come back on that?
Sorry. Maybe it's my mic. Can you hear me now? Yeah. Yeah, so we do a lot of work with colleagues in social care around care workers and care agencies. And one of the things we're looking at is how we might develop sort of joint workforce, joint care across, and sort of care and compassion training as part of that for our staff and theirs. As you know, there's quite a high turnover in those staff groups at the moment. And I think as part of the work we're doing over the next couple of years is, can we develop a career framework so that people coming in can develop their skills, they're likely to stay longer term, and therefore build up those relationships that are key. So it's something we would absolutely recognise and something we're working with councils on.
It's not working. Oh, yeah. Because I keep hearing it a lot of times. It's like a lot of people are leaving because it's like the compassion's gone. So they're going into a job and then they're leaving. And that's why there's so much high demand for. So thank you for taking on board what I said. Thanks.
Thanks, Grant. Shajida, is there anything you'd like to add?
Can you hear me, Paul? Yeah. I'm so sorry I've got my back to you, so I apologise in advance. We have already embarked on doing a lot of work with social care partners in terms of supporting recruitment and retention. You talked about lack of compassion, etc. So we are looking at cultural pieces of work in terms of the environment, the workplace, and what we can do to strengthen that. You know, it's a tough environment. We've recently had the launch of the NHS Workforce Plan. And when we look at developing that, we will be doing it with our social care partners as well. So there are some programs of work already in train. We've already looked at continuous professional development between NHS colleagues and social care colleagues as well, in addition to supporting care home managers around leadership development and wellbeing conversations. So there are things that we are doing in terms of trying to strengthen that relationship, take the good practice that we've got and doing things together. Mark mentioned that one workforce approach. So we have the people plan that we're delivering together across the wider system, and that includes NHS, social care, voluntary care partners, as well as our fire service and police partners as well. So there is a lot happening. I'm conscious you're probably not aware of it all. There's always more that we need to do. We recognise that, but we are co-producing what we do around supporting our care workforce as well, in addition to what we do for NHS workforce. So I hope that gives you a little bit of a flavour of what's going on at the moment, Paul.
Thanks. Told you the big glitches. The next question, I think, was the lady on the end at the back. That's, sorry.
Can you hear me? Yeah. So I'm Louise Connop from Thomas Pocklington Trust, a national sight loss charity, and registered severely sight impaired myself. Back in 2016, July of 2016, so more than 7 years ago, the Department for Health and Social Care put into place the Accessible Information Standard, meaning that as a disabled person, and more particularly someone that is registered severely sight impaired, I should be receiving, and we as a community should be receiving, all of our information and paperwork in a format that is accessible to us. Yet more than 7 years on, the vast majority of people within our community still aren't getting letters and information in a way that they can independently read. There's nobody to be held accountable. It's a standard that nobody really has to currently adhere to. No one seems to be overseeing that. And we've talked, and colleagues here have talked today about the cost on the NHS trusts and the ICBs of no-shows. Quite regularly, we don't know that we're not turning up to an appointment, we're wasting public time and money, but then get taken back off that list because people think we don't want to access that service or need that care. What is the ICB going to be doing to ensure that that standard is adhered to, and that not only we can receive information that we should be allowed to receive in an accessible format to us, but that we have a choice to keep that confidential and not have to share that with someone that can read it on our behalf?
Okay, thank you. That's a really important question. Laura, would you like to come in on what the ICB is going to do?
Thank you, Chair. Hi, we met earlier. I'm Laura, the Director of Communications. This is something that we as a board have heard through the Feets on the Street that we've been doing out with community groups. And as a consequence, we are currently going through all of our CQRM meetings, which are our clinical quality review meetings with our providers, to check that they have the right policies in place around accessibility and around the standards that we would expect them to be adhering to. It is a standard that is in the contract that we hold with all of our providers, so it is something that we can monitor them on. And given the experience that you shared again today, we will pick that up through the CQRM meetings and impress again upon the need for them to be meeting that standard. So it is something that we can hold our providers to account through our contract requirements, and to keep highlighting the challenges that people like yourself and others are experiencing. So that is something that we can pick up in the next round of clinical quality review meetings again. Thank you.
Okay, thank you for that. Sorry, Mr. Fulchand, I think you were next.
My question is rather broad, broader question. Yeah,
carry on.
We focused on a very medical illness model, and that's the significant deficit in here. If we do not address the social determinants of health, like poverty, deprivation, housing, employment, and all the other pollution and all the other factors, then we will still be here 10, 15 years later talking about the same things. I've been a nurse since 1970s, and I can tell the issue here, we've got the cart before the horse, basically. We're focusing on the illness end, not on the prevention end. I think a lot more focus needs to be done into preventing people to be sick in the first place, rather for them to be sick and then we have build hospitals for them. You can build hospitals, but then the problem is who you're going to staff them. And I think nationally that's a major deficit. I think how we go about that is political matter. I think we need to shift from curative medicine to preventative medicine.
Thank you. I think you're entirely right with that. If we just carry on doing what we currently do, we are going to get swamped by the level of demand. If you think 5, 10, 15 years from now, there'll be more people living into older age, but not necessarily living healthier lives. We'll be able to treat them for more illnesses that are currently life-threatening, but technology will develop more cures that will allow them to stay alive, but they'll still need treatment. And you're entirely right. Unless we can change and shift the dial more towards prevention, then we'll never build enough hospitals. And as you say, even if we did, we'll never have all the people to staff them. So this is why I think, for me, there've been lots of reorganisations of the NHS over the years since it was first established. But this one, for me, is quite exciting because this is giving us the opportunity to work alongside wider partners and to do something about shifting that focus. And it won't be easy because politicians, unsurprisingly, are focused on how many people are on waiting lists, how many people are getting treatment against the criteria that we've set. And prevention will take a long time to have an impact. So one of the things we're looking to do is to try and develop more outcome-based measures. So it's not about have we treated somebody for their illness, tick. It's about saying, what outcome do we want that person to have, and how are we going to measure a baseline now, and then be able to see what improvement we made. But for me, that's what the key element of this integrated care system is about. It's 5 years, 10 years from now, saying, well, what difference did we actually deliver? And the difference won't be in how many more people we treat and give them a knee replacement. It will be about, have we changed that focus and started to shift it more towards that prevention, looking at the wider determinants of health, housing, education, etc., and also improved prospects and prosperity in the Black Country. So thank you for that. The lady there.
Hello, my name's Janet Taylor. I'm part of a group called Success that works with the university as a carer and service user. I've got a few questions. One of my main concerns is how many patients are we, because I don't think I've seen it in the report, I may have missed it because of my brain fog. How many patients are we losing to the private sector, i.e. Nuffield? Like myself, I've used the Nuffield more this year than I have the NHS because of poor services. I haven't seen that broken down in here. And also, the NHS is also referring patients to the Nuffield for treatment. I've also been referred. I don't know why, but they did. So that's one of the questions. I don't know if you want me to go through them and then answer them.
We'll deal with that one first if you like, and then we
Okay.
can come to the others. Right? Do you want to come back on that one?
Part of the national policy is that we offer choice of provision, which includes the independent sector. So we've been using independent sector providers for many years as part of planned care. I think the other thing we talked earlier about reducing our long waiters and getting people through. We need more capacity than we have as an NHS sector. So in order to treat the number of people that we do, we have used the independent sector a lot more in the last few years, particularly in areas such as orthopedics, ophthalmology, because they have capacity to treat people at quite large scale, whereas we need to keep capacity for urgent and emergency care, as well as reducing the number of people on the waiting list. If we didn't use the independent sector, we would still see those long waiters for many years to come because we don't have the capacity to treat the number of people that we need to.
Is that recorded?
We can certainly say how many patients we've treated in the independent sector as well as in the NHS. That number is available. There's no reason why we couldn't publish it.
Yeah, I think that needs publishing. The other thing is, and this is a big topic for me, mental health. We know mental health services are dire and they're not getting any better. But when a patient goes into, say, New Cross for physical disability and it ends up impacting their mental health, why is there no services for them? You're in a hospital, for God's sake, right? The staff are trained on mental health. I know that because I teach them, right? I teach them at the university. We know GPs are trained on it, very little though, but they are the gatekeepers in sending us for services as service users, which we do not receive. I mean, I've had to push my doctor and other people have had to push my GP to get me to see a psychiatrist, and he spent 2 days trying to get me to see a psychiatrist. It's absolutely dire out there. And if we want to improve suicide rates, we need to do something now. People shouldn't be waiting 4 to 6 weeks. This is what I've been told. I don't know if I can last that long. Well, we'll know by the next AGM. If I'm here, you know I haven't. If I'm not here, sorry, you know I haven't lasted. But I think this is the brain with me. I think something needs to be done in the hospitals because what I've last seen in New Cross, I will never go in the hospital again. And the PALS system that you've got in place is not fit for purpose, nor is a complaint system with GPs or pharmacies. They're absolutely ridiculous. I put in complaints, and if you see the response, I haven't received a response from 2 people. And my complaint to the hospital went to David himself, David Loughton. And it was, I was asked to give them an extension, and I can show you on my phone what they actually said. It's a joke. So, you know, where do I go next? The press? You tell me.
Thank you. Mark, do you want to come in?
Yeah, I'll pick up the various points. So firstly, on mental health support when you're in a hospital like Royal Wolverhampton, it's something that we absolutely recognise as a gap. And if Marsha Foster were here, who's the Chief Exec of Black Country Healthcare, she would be talking about how they're expanding psychiatric liaison teams in all 4 of our hospitals, recognising that demand is going up and the pressures that the physical health staff are under in terms of delivering just on that physical health area alone. And as part of that, and despite all the financial challenges we have, our mental health investment in the system is completely protected. And we have to report nationally to make sure that every penny that we're given as a system for mental health is spent on mental health. And quite happy to share the detail of what's in those plans because we continue to grow and develop and recognise that we need more capacity in that space. In terms of the complaints, the issue you've raised around Royal Wolverhampton, happy to pick up after because our time to talk team, I think, are in the room from the ICB if you want to talk further about how we can resolve that with you. On the pharmacy, the dental and optometry, we took responsibility for that complaints handling earlier this year. And we're aware there is a backlog that we've inherited from NHS England of those complaints responses. And we recognise that response times currently are not where they need to be. But through Laura and the team, particularly for pharmacy, optometry and dentistry complaints, and for primary care GPs, we're doing a lot to try and improve those complaint response times. So an apology that you've waited so long for a response in that particular area.
Do you want to come back on that?
Yeah, time to talk I've been to, tick box. What was it, NHS England, absolutely ridiculous. I went through the whole Health Watch, not the one that ridiculous one we got now. The one we got now that Tracy was involved with, they helped me immensely to try and get a response. I couldn't even get a response from NHS England. Do you know where I had to go? To my MP to get a response. So they're not fit for purpose. The whole system isn't fit for purpose. And this is why I'm saying you can see why people go to the press. Because if you are not addressing the issue, where are they supposed to go? The other thing that you haven't answered, the fact that nurses and GPs are trained on mental health, and yet where is the care for mental health service users in the hospital and also to do with the GP practice? It's a lot. It's a joke. I'm having to tell the GP what to do. That is just ridiculous. And as you can see, I can speak up for myself. There's others that can't. You know, I shouldn't have to be doing people's work for them, and yet that is what I'm having to do. So I'd like an answer from the GPs, please, because if Dr. Dan DeRosa was in the room, God bless him, right, he admitted they are not giving enough training. It's you go and do an extra training for mental health. So why are we then sent back to GPs? That's all I kept getting. You're suicidal, you've got to go refer back to GP, you've got to refer back. Why am I being referred back to somebody who knows very little about mental health?
Ananta, do you want to talk more about some of the primary care training that we're doing, particularly around mental health and suicide prevention?
Yes, thank you, Jenna. Firstly, I just want to, I hear about the experiences you've gone through. I'm really sorry. I know that you are speaking up about it so that we can do something, but I'm sorry for all that you've gone through. We do have a training program for not only GPs, but all professionals working in primary care, whether it's nurses, allied health professionals, etc. So we have something called the training hub within the Black Country ICB, which provides training to a range of primary care professionals. And we have recently expanded the mental health training that's available so that it takes into account some of the things that you've mentioned. For example, we've now got suicide prevention training as well. For me, I think there is something about, once again, the mismatch between demand and capacity, but also I think to look at the training that is being offered, and continuously keep getting feedback about its quality and how it is actually helping people do their work within primary care services. So it is something that we do on a regular basis, and we also try and have more mental health trained, what we call ARR is the additional reimbursement scheme program, which allows mental health trained staff to actually work within primary care services. So between the training program and between having these various professionals in primary care, the aim is to try and make sure that the right skills are there in primary care to help those who are referred, either referred back to primary care or they come to primary care in the first instance. But I appreciate you saying that there doesn't seem to be either enough of it or not, or those who are going don't seem to be getting the help they require from a mental health point of view. That is something that I will take back and work with my primary care team to see what it is we can do to get it right and to get it better. Thank you for raising it.
Thank you. I'd just like to say, because of how I'm feeling, I've got a tumour, and I've decided, and I've told them, don't waste your money on me. Whatever happens, happens, because I am not going into another hospital to go through what I've just gone through. So thank you for what you've already done for me in the past. Well, I will not be using the service in the future. I'll go private. Thank you.
I hope that you may reconsider that, but clearly that's your prerogative. So the lady there.
Hi, I wasn't going to speak today. I was just coming as an observer, but hearing people speaking has given me a voice to speak. My name's Kimberly Richards. I'm 38 years old, and I've suffered with chronic pain for 35 years. I feel as though the NHS hasn't supported me as I should have been. There have been a lot of inequalities. I have a lot of chronic pain flares and problems with my body. I'm not a doctor, so when I go into a doctor's surgery, the NHS service, the hospitals, emergency services, it's very hard to explain what's going on. But on the same point you made, in investigating and looking deeply, root cause of what these things are and early diagnosis has been very delayed. I have a child, she's 15 years old. She has a similar health condition to myself. It's not as severe. I want to know that in the future, the NHS can do more for her than it has done for myself, so that she can stay in education, work, and things like that, where I have had to step back from because of my own health, not because of passion or not wanting to do it, because of not having the support and the health support put into place at the right times when they were needed. So I just want to know what's going to be done in the future for people who suffer with chronic illness and pain. What is going to be done to make the services better?
Okay, thank you. Sally, do you want to come in on that?
Yeah, thank you. And I'm sorry that you're experiencing what you're experiencing and talking so eloquently about your daughter as well. So I'm Sally Roberts, I'm the Chief Nurse for the Black Country Integrated Care Board. And the work we're doing in place actually, so working within our local places, Walsall, Wolverhampton, Dudley and Sandwell, working with primary care colleagues predominantly, but also through out of hospital services, so working with our community colleagues and working with our social care colleagues, and our mental health colleagues collectively as one team, so that from a patient perspective, it should be seamless. You shouldn't feel that you see one practitioner and then you ask another same set of questions 27 times over, and that we work collectively as one team, looking at the patient at the centre of that, and then wrap around those services in terms of need. And that also includes working with local authority partners from a housing perspective, from a care benefit perspective, from an independence perspective, and really driving, the agenda in terms of from your perspective. That's not without challenge, so that's about some hearts and minds as well as looking at policy change and looking at how differently we work. But I think in the Black Country, there's an absolute commitment, there's an absolute passion to doing that. We've got quite a long way down the road in terms of some of that work, and particularly around some of the acute focus we've got within community services and the interface that we have with our acute hospitals in that, so that we reach into hospitals from home rather than the hospital pulling out from back into community. I'm happy to pick something up outside separately with you from your personal perspective, but the agenda that we've got is really driving that community service and that wraparound arrangement in terms of the agenda going forwards. Thanks.
Thanks, Sally. And yeah, sorry, the lady there.
Hi, good afternoon. I just want to raise a question regarding GDPR, data protection. So recent experience of staying in New Cross Hospital, I appreciate the fact majority of the medical staff are very careful about data protection and GDPR. But I also experienced listening to nurses talking about patients' sickness, issues, some very sensitive issues, joking and laughing about it in the corridor where the patient could actually hear it in the ward. And that actually upset two of the patients really badly. I manage a small charity, and obviously, like yourselves, we are subject to the GDPR rules as well. I would never allow any of my staff to be able to do that, to discuss clients' private issues, and we deal with a lot of vulnerable people. So I just think there are some serious issues with a percentage of the staff who are working in NHS that either training around GDPR needs to be refreshed or emphasized again, that they need to, and including even myself. I remember there was a handover in the morning and I could hear everything that the senior nurse was telling the other person. It was a sort of a complaint about me, but it was a very sensitive issue. I'd lost a family member, and then I was put in a ward exactly opposite where somebody was dying. And I asked to be moved, and that was a big thing. And they made a big thing out of it to say why I was asking to do that. And I wasn't coping with it very well. 2 days before, I had lost a family member. So I just think when members of the medical teams are discussing patients, they need to discuss it privately. We are human beings, we are sensitive. And quite often when we are in hospital, we are ourselves very vulnerable at that time. So I think issues around GDPR, data protection, is a very crucial issue. Otherwise, one of these days, you're going to have a major incident that will be blown up in the press or something. Okay, thank you.
Okay, thank you. Mark.
Yeah, thank you for sharing that, and I'm sorry to hear about your experiences. I will take it away to speak to the chief executives in all of the organisations, to remind them of the importance of confidentiality at every time, and to make sure, and I know many hospitals do this, that all their staff are up to date in terms of GDPR and confidentiality and how they use patient information. So thank you for raising it, and I will make sure that I raise that directly with my chief exec colleagues.
Thank you.
Thank you. In which case, I think we'll, conscious of time, move on, Penny, to the questions that are online.
Thank you. There is actually one question in the room, which is from Deirdre on behalf of Zebra Access. So her question and comment is, I'm disappointed to see that future plans does not mention deaf and disabled people. After all, they are the highest percentage of healthcare users. As someone who speaks for the deaf community, how do the ICB propose to increase better accessibility for the deaf community? As interpreters are not enough, they cannot access telephone appointments, written information and more. I keep getting told that accessibility will be factored in, but it's not included in the language section of the ICB website or any language service offers. We have to ask every time. This is an Audit system.
Okay, thank you for that. Laura, do you want to come in on that?
Yeah, thank you, Chair. It's Laura Broster, the Director of Communications for the ICB again. Hi, Deirdre. Hello. So I did cover this in part in response to the other question around how we're working with our providers to ensure that they are meeting the accessibility standards. In addition to that, I think there is something that can be helped with our new shared care record, where patient preferences being recorded about their needs for accessibility or specific communication styles can then be made available in a summary for everybody who's accessing their care, so that that may help us to not need it being requested every time. In addition, the particular question about the ICB website, we are already looking at other ICB websites where they seem to have made better progress than we have around BSL. And we've got a particular focus on Nottingham ICB at the moment, and we're very happy to work with Zebra Access around the way that Nottingham have pulled together specific resources on key health topics and had them translated and produced in BSL version. Obviously, as you'll be aware, Deirdre, thank you to Zebra Access, who have supported us a number of times with our key public communications around things like the Joint Forward Plan. And indeed, today, through this AGM, we have worked really hard to find interpreters. I would say, though, that we do absolutely recognise the challenges in that space, and that is being proven today by us having interpreters online rather than in the room as well. So we recognise those challenges, and we'll continue to work with Zebra Access. Thank you very much.
Thanks, Laura. Mark, do you want to add anything?
Yeah, just on the wider issue of service delivery and how do we grow and expand services to recognise the demands that we meet. We're very conscious that digital has a huge part to play in that, but equally that not everybody has the ability to access digital services. And certainly in our last board meeting, one of the advantages of the way the ICB is formed is that we have local authority partners around the board who quite rightly challenged us to say, we want to see more information around how do you ensure that if you're expanding digital services, they are accessible in the right way. So at the board this afternoon, in public board, it's on our website. You will see a paper that describes in more detail how we are being mindful as we grow digital services, that they are accessible for all parts of our population.
Thanks. Penny.
The next question was from Jenny Mason. She's asked, how can we improve things for patients who wish to move out of the Black Country to other NHS trusts to obtain better treatment and options for rare conditions such as NET cancers that are not understood by our local authority? It seems there is a negative reaction to people who wish to do this.
Thanks. Geraint, do you want to come in on that?
We would offer patients a choice to go to any area they wish. We can support with things like transport to if they're having difficulties getting there. We also have arrangements that if people have to travel for a procedure, they can receive their care back in the community. I think there's something around the relationships between our own hospitals and those very specialist centres, so that you're travelling for that specialist opinion when you need it, but then your day-to-day care can be provided in your local community. But happy to work and follow up a specific example.
Thank you.
Another question, I'm hoping I've pronounced this correctly, Mariette Mulvina. How long does it take to get to see an audiologist, and is there any help available for those who need it afterward?
Yeah, Mark.
We'll have to come back on that one. Look, I haven't got to hand unless anybody in the room has the current waits for audiologists. I think what we said at the start was we published the questions and answers on our website, so we will go away and get the exact detail on that. So if the individual that submitted the question, and if we've got the ability to go back to them individually, can we do that, please? Thank you.
Thanks.
There was a comment from Deirdre answering that question, if you want me to read that out too. So Deirdre, obviously with experience, has said that you need to be referred by a GP to an ENT who will refer you to an audiologist. She believes the current wait is 24 weeks for an assessment, then 12 weeks to get ear molds made. Again, as I say, it's based on the experience that Deirdre's had.
Okay. As Mark says, we'll check that and confirm it. Are there any others online?
There's one more, if I can get my laptop to go up. Another question here from Lorraine, I can't see her surname, Lorraine Crampton. She asks, can you tell me how the additional roles will be developed moving forward within GP practices, community hospitals? Oh, sorry, community and hospitals.
Thanks. So.
Yes, so we have a whole series of programmes bringing in additional roles. They've been working with our primary care networks for a few years now. And there is a running period in terms of training so that they're fully trained and they're able to be patient facing. And that does take sometimes on average about 2 years. Just so that you know, we as an ICB, we've been the most successful system across the Midlands in terms of recruitment of our staff. And I think we'll see the benefit of that, particularly as people go through additional training. We are slightly underspent on the IRR's budget, so we are looking at flexibility on how we're going to use that underspend during this year. And one of the discussions we're having with the national NHS team is about flexibility to use that R's funding so that we can prioritise some of the health inequalities that we got in our own area. So I think there's some good work already done. We're continuing to work on that good work, but also looking at potentially developing other flexible additional roles going forward.
Thanks. So I'm conscious that we've reached the time that the meeting's meant to end, and I think we only have the BSL interpreters with us until now. So if anybody else has anything they want to raise, we're all here for a while, so please come and talk to us, or alternatively, if you've got a question you'd like answered, go and speak to Laura, and we'll make sure that that one's included in the chat and the answers that go onto the website. So that draws this first annual general meeting of the Black Country Integrated Care Board to a close. I'd like to thank everyone that's been involved in organising the event, and also thank the presenters, Tom, Alan and Mark. But most of all, I'd like to thank you all for coming and for watching, and thank you too for the interest that you've shown and the questions that you've asked. As I said earlier, all of the questions and the answers, including any that come in late, we'll put on our website. So all that remains for me to do is to thank you again and to wish you all a safe journey home. Thank you.